I'm in a technical desert here today. Sorry.
No worries.
Did I interrupt you?
No, we were just letting everybody in, so your timing is perfect.
Okay.
So we're ready to go whenever you are.
Good to go. All right. Good afternoon. Thanks everybody for being flexible in doing this afternoon. We have four wonderful presenters with us today. But as we always do, I'm going to talk a little bit about sort of where we are. I have some good news to share as a result of this collaboration. We, right now, 10 days, 15 days, whatever it is, till the end of the year, are able to report that for this year, in terms of non-suicide opioid overdose deaths, that we have seen in Middlesex County, and again, we do not do this alone, a 31% decrease, which is a phenomenal number. And as I know, I've said to lots of you many times, the fact that 10 or 11 years ago, we would get to this place, and one death is one too many. But thinking again about that circle of people who are left behind, the fact that we would get to a place where we've reduced that number by 31% is really amazing. And it's a great credit to everybody on this call. Now, what tempers that is that we are continuing to see an uptick in what our troopers are calling, and remember the bar is pretty high, a death by suicide with the use of opioids. So when we think about what's the work ahead, I would say that is probably primary in our work. So just a couple of updates in addition on some other things that have been happening. A week or so ago, we hosted a ransomware response conference for our hospitals, schools, and universities, and cities and towns. We had a host of great speakers, including U.S. attorneys, former U.S. attorneys, law professors. Lowell, in particular, knows well about these ransomware attacks. They spent an enormous amount of money and lost an incredible amount of time trying to get back information that belonged to them when they were the victim of a ransomware. And it's no longer just federal agencies or big corporations. Literally every sector is being affected by these. And what we really talked about is both how to protect yourself, what are the immediate things to do in the aftermath of one of these attacks, and how do we move forward if something has happened. And we also talked a lot about the question of, do you pay, do you not pay? What do you do to try to get back information that is yours? The event was well received, and it underscored what I've been talking about in terms of the numbers, and that is just the value of partnership, the way that it allows us to share resources and help our communities be protected with that guidance. And then just the day before yesterday, we hosted a large roundtable talking about safety in the workplace. We had the representatives from Fortune 500 companies in Middlesex, of which we have a lot. We had our colleges and universities, our hospitals, our local police departments. And it was really triggered. We've been doing workplace violence for a long time, but this meeting the other day was really triggered by the murder of the United Healthcare CEO in Manhattan a couple of weeks ago. And really just thinking about how do we put protections in place? How do we respond to threats? And of course, immediately after that, we had the shooting in Wisconsin. And we don't always think about this, but, particularly for places like UMass Lowell, that's a school, but it's also a workplace for a lot of people. That school in Wisconsin, 400 families sent their kids there, but it was a workplace for a lot of people too. And what happens when there's the criminal prosecution and investigation that can arise in those incidents, but what do you do about the people? I mean, as I'm sure many of you are, as you listen to that, the person who made the 911 report in that case was a 7-year-old second grader who made that call. And when we think about some of the things we have talked about here, the ACEs test, the fact that kids who have childhood trauma are more likely to become involved in substances, I don't know what could be much more traumatic than 7 years old and you've got gunfire in the hall of your school. So how we respond to that and what we're doing with it is a really important piece for us. So I'm also really excited to share with you some details about our January meeting, which we will be holding in person for the first time in a very long time. And it arises from something we've been seeing here in Middlesex and something that you may have seen in the Department of Public Health bulletins that have found that of the working age residents of Middlesex County, so working age people who died between 2011 and 2020, they were 35% more likely to die from an opioid overdose if they'd been hurt at work. So somebody who had a workplace injury, and either because of surgery or lingering pain or whatever it is, and they then become acquainted with opioids, they are 35% more likely to die of an opioid misuse. And that really highlights the critical piece that employers and community organizations have to play. And I have to say, for the district attorney's office, we respond when there is a serious workplace accident. So if we have a crane go over or a dump truck backs up into somebody, any of those kind of things at a workplace, we are responding. We are increasingly responding to those incidents. And we are increasingly seeing that opioids play either a confirmed or a suspected part in a number of those. I'm very pleased that we're going to have the former mayor of Boston, the former secretary of labor, and the current executive director of the National Hockey League Players Association, Marty Walsh, join us in person for that meeting. We're also going to have a number of other leaders in that area, the construction companies, the subcontractors, the unions, and talk about what they've been doing, talk about what resources are out there. So I'm looking forward to that. We'll have more details to share about that end of January event as we go forward. And it will be actually really nice to see everybody in person. But turning to today's meeting, and in light of Veterans Day just last month, we're going to hear from 3 speakers who have dedicated their work to addressing substance use disorder among military members and veterans. And again, looking at the research in this area, the 2023 National Survey on Drug Use and Health reported that 2.8 million veterans, and that's 14% of the veterans in this country, struggled with substance abuse during 2023. And I have to say, last night I had occasion to drive through the theater district in Boston, and I couldn't read the small print of it, so I don't know what organization it is, but they've got lots of billboards up about if you are a veteran and you are struggling with substance disorder. With the sign said, you know, if you're struggling, you don't have to struggle alone, and then gave you a QR code for some resources. And we know that veterans are particularly vulnerable to substance use disorder for a number of reasons. Number one, and this is true for many people in this area, medicine has advanced so much that, like others, combat veterans survive injuries that they may not have survived 10, 15 years ago. And it may leave them with lingering medical conditions or chronic pain. Many veterans are prescribed opioids to mitigate that pain. And then on top of that, they've got the stresses of reintegrating after a deployment. They may begin to misuse those opioids or turn to another substance. And again, last year, 632,000 veterans, so over 500,000 veterans aged 18 or older, misused opioids, according to the National Survey. And there's also the mental health challenge. We've talked endlessly at these meetings about how often they co-occur, but we know with veterans, between the deployment, what that causes in their personal life, the combat exposure, the reintegration, many veterans are struggling with substance use disorder who have PTSD, depression, or anxiety. And that number, we know in addition to those who are misusing, we've got over 1 million veterans who've got a co-occurring substance use disorder and a mental illness. So, and of those who have a mental illness, they are most likely, if they are misusing something, it is most likely opioids. So we have all of those factors. And then what do they do in terms of treatment? There are two primary issues, really stigma and accessing and completing treatment. Many veterans, they've been trained with the mindset of focusing on the good of a unit, feeling tough and strong. They are reluctant to go and ask for help. Treatment can be a complex issue. Only 1.1% of people with veterans with the substance use disorder sought treatment. 3% of those struggling did not seek treatment, but did think they would benefit from treatment. And 95% did not see a need for treatment. So that's a whole piece of, will they ask for treatment? Are they able to get treatment? Are behaviors that might have been normalized while they were deployed, smoking, heavy drinking, prescription drug misuse, all of those things, they come home with them? And how do they deal with that once they're at home? So, we have almost 50,000 veterans here in Middlesex County. And when I talk so often about making sure that everybody knows that they belong here and can access things, this is a very important population for us to be talking about and thinking about in terms of treatment. And of course, most of our veterans have access to the VA health system, but many may not be using that, may not be convenient. We have a big issue in the western part of this county about people getting to medical care. Where is that care? What can they do to make those? What can we do to make those resources available? So we're going to turn to our first speaker, who's Dr. Rachel Adams. And Dr. Adams is an associate professor in the Department of Health Law, Policy, and Management at BU School of Public Health. She is an addiction health services researcher, and her expertise is in studying substance use, disparities in treatment, morbidity and mortality outcomes in a high-risk population, including military members, veterans, and people with traumatic brain injury or another disability. And obviously, there can be lots of overlap there. Dr. Adams is the principal investigator of the Substance Use and Psychological Injury Combat Study, which has had continuous National Institute of Health funding since 2010. And prior to working in that role, Dr. Adams led a portfolio of addiction health services research for over 10 years at the Institute for Behavioral Health at Brandeis University's Heller School for Social Policy and Management. Her research has been supported, as I said, by the National Institute of Health, the National Institute on Disability Independent Living and Rehabilitation Research, and Uniformed Services University at the Department of Defense. Dr. Adams has an appointment as a health services researcher with the VA administration, Rocky Mountain Mental Illness Research, Education, and Clinical Center in Aurora, Colorado. And she's going to talk to us today about her research on substance use disorder among military members, both current military members and veterans across the country. So, Doctor, thank you for being with us.
Thank you so much, DA Ryan. I am just going to share my screen and get this set up, and then I will begin. Okay. So we are good to go, right? Yes. Okay. Well, I can't see this. I only see my slides, but interrupt if something goes up that I need to know. I am really, really thrilled to be here today and to speak to this group about the work that I've been doing with my colleagues over the past 15 years, focusing largely on at-risk substance use in military and veteran populations, primarily focusing on the cohort that served and deployed since 9/11. And I want to acknowledge funding from NIH and also Uniformed Services University, and also just mention that what I'm presenting today represents my colleague and my opinions and not those of our funders. So DA Ryan, you led a great introduction to this topic, and I'm going to hit on some of the themes that you introduced. We've known for decades that military members and veterans are more likely to engage in risky substance use and to develop addiction. In fact, in 2013, the Institute of Medicine, now the National Academies of Sciences, convened a panel to study this specific issue. And when they came out with their final report, they declared that substance use in the military constitutes a public health crisis. And the concern for the military population was primarily at the time alcohol. In fact, studies have found, the National Health Interview Survey has found that military is America's heaviest drinking profession. So military members report more binge drinking days per year than any other occupation. And military members and veterans have been disproportionately impacted by both the suicide crisis in the United States and the overdose crisis. And I like to focus more attention on how substance use plays a large role in both of those crises, which has already been introduced today in terms of recent deaths in the district as well. So as I mentioned, while in military service, concern has been very high for unhealthy alcohol use. Post-deployment is really a high-risk time. And with the 15 years of heavy deployments that we saw since 9/11, drinking really can be used and has been used to self-medicate or cope from trauma experienced during deployment. And our own research with our studies at Brandeis and BU has found that over 40% of military members who deployed to Afghanistan or Iraq screened positive for at-risk alcohol use in the year returning from deployment. And then we also observed numerous missed opportunities for using that screening information and intervening early. As we know that treatment for alcohol use disorder can be effective, but many barriers exist. That's true within the civilian setting in our country, but specifically within the Department of Defense, there are additional numerous barriers. Specifically, stigma is very real, and the lack of confidential treatment. So for many years, traditionally, people identified with an alcohol use disorder in the military, if they required treatment or referred for treatment, their commander is also notified and involved in that ongoing treatment. So it's not confidential. And in fact, it can be career ending. And because of this, there's many incentives to sort of not disclose or not have open conversations with providers about risky alcohol use. And at-risk alcohol use remains a serious threat, not only to the health of the military members and their families, but also to military readiness, which is really the primary mission of the Department of Defense, to have a fit and ready force to be available to deploy at any moment. So illicit drug use has been low in military populations, largely in part to since the 1990s, the DoD has implemented a zero tolerance policy for illicit drug use in the military, and they implemented a random urinalysis program. So military members know that, and it really has kept the rates of marijuana and other illicit use low. However, military members have not been immune to the ongoing overdose epidemic impacting the United States, and this initially stemming from very high prescription opioid receipt. The Institute of Medicine report found that between 2001 to 2009, the number of opioid prescriptions written by military doctors quadrupled. And since 2010, the DoD initiated numerous policies to reduce overprescribing in response to the high rates of long-term opioid receipt. In one of our studies, we looked at over 500,000 active duty soldiers who returned from Afghanistan or Iraq deployments between 2008 and 2014. And we found that over a third of them received at least one prescription opioid in the first year following deployment return. So that's a very high base of opioid receipt that can impact future use of opioids. Another thing I want to point out is that this is from a Government Accountability Office report in 2017, that among all military members who separated from the military with a misconduct separation, 29% of them had an alcohol-related disorder diagnosis, and 20% had a different substance use disorder diagnosis. So this suggests that these diagnoses are often associated with a stigmatizing and unfortunate separation type. And 23% of those individuals with a misconduct separation received an other than honorable separation. And that can really have negative implications for future job options and also for eligibility at the time to use VA services. So once military members leave military service and become veterans in our communities, we do observe that rates of illicit drug use increase among military members. One study of OEF veterans found that between 2001 and 2009, over 11% of veterans who used the VA for the first time had a substance use disorder diagnosis. Most of them had alcohol use disorder diagnoses, and 5% had drug use disorder diagnoses. These veterans were more likely to be male, very young, under age 25, never married, and have had experienced combat exposure. And importantly, over half of them and up to 75% also had a comorbid PTSD or depression diagnosis. And we observed that opioid prescribing in the Veterans Health Administration escalated during the early phases of the opioid crisis as well, similar to within the DoD and the VA in the civilian settings. And after opioid prescribing started to come down after around 2010, there was still an increase, a 50% increase in overdose fatalities among veterans using the VHA between 2010 and 2019. So as has been alluded to already, excessive substance use increases risk for death by both overdose and suicide among military members and veterans. We know that veterans in the United States are disproportionately at risk for death by suicide, and veteran overdose deaths have been increasing at parallel rates to civilians. Alcohol-related overdoses among veterans have also been increasing, and this is primarily due to polysubstance use deaths, specifically opioids and alcohol in combination. And studies with veterans who use the Veterans Health Administration have found with those with substance use disorders have increased suicide risk. And this is particularly true for women veterans and those with comorbid psychiatric conditions. And substances are commonly used preceding suicide-related deaths for veterans. So another thing I just want to draw attention to is that among this heavy substance-using population, military members and veterans also have access and training using firearms. Military members are trained to use firearms with precision. Almost half of veterans own a firearm compared to about a third of other adults in the US. And military members and veterans are at higher risk for firearm suicide compared to civilians. 7 of 10 veteran suicide deaths are a result of firearm injuries, and over 90% of suicide deaths by firearm are from personally owned firearms. And firearms are a very deadly means of suicide, particularly if you are trained in using them. So now I'm just going to very briefly talk to you and introduce you to this study that I've built with colleagues over the past 15 years called the Substance Use and Psychological Injury Combat Study, or SUPIC. This is a cohort of almost 900,000 Army soldiers, both active duty and National Guard, who returned from Afghanistan or Iraq during fiscal years 2008 to 14. And for this cohort, we compiled person-level data from various DoD data sources, including deployment history, all of their military health system, electronic medical record claims data, pharmacy data, which allows us to look at opioid receipt, post-deployment surveys, where we've been able to look at risk alcohol screening and other mental health conditions and TBI. And we know when and why military members separate from the military. We've been able to do a variety of studies focusing on substance use, mental health, pain, opioids, Alcohol, we are completing a study focusing on suicide risk in this population. And really importantly and uniquely, we've had permission from DoD to follow this cohort and partner with VA colleagues and see who leaves military service and who does indeed go over to VA to use care there. And then we've been able to do longitudinal analyses between both systems of care. So I'm going to conclude by showing you results from one of our recent papers that I think really relates to the topic of today's panel, where we did an analysis in this cohort looking at risk for accidental death after return from deployment. And I want to think about considering the role of substance use in these different types of accidental deaths. So among our large cohort of soldiers returning from deployment, we observed over 10,000 all-cause deaths through the end of 2018, which is when the mortality data was available through. And in fact, the most frequent type of death in the cohort was accidental death. So over 34% of deaths were accidental and 27% were death by suicide. So that means that 2/3 of deaths from this large cohort were preventable. They were accidental or suicide deaths. Among the accidental deaths, the majority, 46%, were motor vehicle accidents and 36% were accidental overdose deaths. Highest accidental death rates were among males and junior enlisted, which are the largest population. So here is the main results in a figure. And you'll see that the top bar is just the trend in accidental deaths. And what's important to look at here in this figure is that from left to right is years since return from that first deployment ending in 2008 to 2014. And then we look out for risk of accidental death moving forward in time up to 11 years later through 2018. And we see that when you look at motor vehicle accident death, risk for motor vehicle accident death in red compared to risk for accidental overdose death in green, that we're observing a really divergent trends. And what we see is that risk for motor vehicle deaths was particularly high and elevated in the first couple years after returning from Afghanistan and Iraq, and then proceeded to go down over time. And on the other hand, accidental overdose deaths were lower in the first couple years after return from deployment and then start escalating upward over time. And there was really no indication that that was going to level off or decrease in what we observed. So just to summarize here, accidental deaths were the most common type of mortality in the cohort, and motor vehicle deaths were particularly high in the first few years following deployment, suggesting that interventions in the immediate post-deployment period to reduce dangerous driving and efforts to reduce driving while under the influence of alcohol may be particularly critical. And then what we observed about accidental overdose deaths increasing over the next 11 years is particularly concerning and alarming. And this suggests that evidence-based prevention and intervention should be implemented and sustained, we recommend indefinitely, for military members and veterans who deployed to Afghanistan and Iraq. And what I think I want to focus on here is that many veterans do use the Veterans Health Administration, but many do not. And they're in our communities, and it's possible that providers and civilians and people working with them in civilian settings don't know their veteran status and that they may be at elevated risk. So really thinking about more screening for veteran status and how we can be more aware of this history. So this is the last slide. I do have a QR code here to some suicide prevention resources in the VA. This figure about, lethal means safety and how to communicate to veterans about safely storing their firearms in their home. And then this last quote I'll just mention is a quote we had in one of our papers where we focused on at-risk alcohol use while in military service. And we said, we contend that unhealthy alcohol use may be a canary in the coal mine, meaning that it's by not addressing it earlier, it really is potentially undermining other important public health interventions in this population that are so critical. So I look forward to more discussion with the group later. And this is my email. If anyone wants to reach out at any time, please do so. I'm going to stop sharing. Okay. I think, should we save questions for the end?
Thanks, Doctor. No, we're happy to, sorry. We're happy to take questions, comments, if people have any. And Alice, if you can, we're still trying to fix my access here, so I can't see if people have their hands up.
Let's see. Just screening. I don't see any hands. Looks like we're
good?
Yep, we're good.
All right, we will share all of that information. Thank you so much, Doctor. And our next speaker, Dr. Dong Chan Park, is currently the medical director of recovery services at the Bedford VA Hospital. He oversees the psychiatric aspect of the partial hospitalization program, the intensive outpatient program, the residential program, and the substance use disorder specialty clinic at the Bedford VA. He is also an assistant professor of psychiatry at BU's medical school. And Dr. Park himself went to medical school at Rosalind Franklin University. He then did a psychiatry residency and addiction psychiatry fellowship at BU Medical Center. So, Doctor, thank you so much for being with us.
No, thank you for having me. Thank you for inviting me, and thank you for giving me the opportunity to talk about the things that we do in Bedford VA. So it's really an honor, and and I think all the statistics and all the public health perception was covered by Dr. Adams. So I'm gonna skip to what we do offer in Bedford VA and how we are hoping that this community collaboration can help us engage our veterans even further. So. As we've heard that the veterans are at increased risk for substance use disorders, also chronic neck and back injury, which leads to opioid prescriptions, which can increase their opioid use disorder risk, and as well we also know that they're also at increased risk for suicides. So in response to that, the VA even from the central office stepwise. We've been very much focusing on how to reduce the risks and how to increase the treatment access for our veterans. For Bedford VA, we do have acute inpatient psychiatric unit that also doubles as our detox unit. We also have a 28 days substance use disorder residential program. It's actually a brand new unit that opened in 2024, and also 90-day homeless rehab program. That's also a residential program in Bedford VA. And we also have a supportive housing, and we also contracts, a lot of para, veterans organizations that provides the temporary housing for our veterans. We also have our, Section 8 equivalent housing voucher in HUD-VASH program with the intense case management to kind of help them get into treatment. In an outpatient world, we also offer our partial hospital program. This runs from groups from 9 a.m. to 3 p.m. from Monday through Friday. We also offer virtual intensive outpatient program, and as far as I know, it is a unique in the state of Massachusetts. So we do have 3 VAs in the state of Massachusetts. We have Northampton VA and we have Boston VA. But Bedford VA is the only one that offers the virtual IOP. We run groups from 4 p.m. to 6 p.m. from Monday through Thursday that accommodates veterans who have otherwise obligations with their job and families during the daytime, and they can still access their treatment at home. We also have a specialty stud clinic, and we prescribe, we treat veterans with the opioid agonist treatments in buprenorphine formula. We also have a naltrexone and also their extended release intramuscular injection formula. And we found that that's really the key portion of treating patients with the opioid use disorder. We do not have methadone clinic. So currently, the only VA methadone clinic is out of Jamaica Plain, and for a vast majority of our patients who are on methadone clinic, they cannot get to JP on a daily basis. What we do is then we utilize our community care funding to pay for veteran services to get methadone from community medicine clinic, and that's considered as one of our top clinical priorities. We try to get them into treatment as soon as possible, even without and even a day of lapse is just one day too much. And that's been going very, very successful. Um, Almost all our patients, I think, they are getting their medicine clinics from Lowell, and also there's a Waltham, there's one in Auburn, and there's one in Gloucester. So we collaborate with the community medicine clinics. We do have CBOCs. CBOCs stands for Community-Based Outpatient Clinics, in 3 different locations. So we have one in Haverhill, one in Gloucester, and one in Lynn. Now, we also collaborate a lot with the Northampton VA. They have a very big CBOC in Worcester, and they also have a very robust substance use disorder services, but they do not have a partial hospital or IOP. They do have and for their inpatient needs, they'll refer them to their Northampton location or to Bedford location or to Boston location. But they do have a very robust, specialty stud clinic in Worcester. So we make sure that our veterans get adequate treatment access. The patients, if they want, they can be started on buprenorphine medication on the same day. Like I said, we don't have access to to methadone from our own VA, and the because of the special property of the medication, for them to start naltrexone, extended release naltrexone, it's going to take several days before they're safe to receive the medication. But otherwise, we have a walk-in clinic and urgent care that's open from 8 to 4:30 p.m. From Monday through Friday, and we try to facilitate our veterans getting treatment as much as possible. Dr. Adams kind of touched up on this. There's a lot of stigma about the opioid disorder and the treatment as well from the veteran side. Um, I often find that I like to think that we've done a lot of work in the front of the VA hospital to be able to offer medications for opioid use disorder. And frequently, if I'm running into a barrier, it's actually often from the patient side. I hear a lot of stories about them not wanting to be on buprenorphine medication or methadone medication, and they often say that I don't want to be hooked on one thing after getting off of fentanyl. I don't want to be hooked on this. Isn't that just another drug? So that's another aspect of education that we're continuing. But I'd also appreciate kind of the messages of destigmatizing the treatment of agonist treatment or other treatments to our veterans population. One thing that I did want to highlight is that we have access to Veterans Justice Outreach social workers. So those are the specific team of social workers there, and we have a VJO from Amy Buxbaum there right now, just getting on. So Amy, I was just talking about the VJO services that we offer, and if you kind of want to take over and explain what VJO is, that'd be great.
Yes, thank you, Dr. Park, and I apologize for logging on a bit late, just dealing with a couple of things earlier today. So Veterans Justice Outreach programs occur throughout the country, and in Massachusetts, we are sort of divided by county. So each Veterans Outreach clinician covers a county in Massachusetts. We are what's considered an outward-facing program, meaning our main goal is to be able to help identify veterans that might be engaged in some manner in the criminal justice system and outreach them and provide options of either engaging into treatment at the VA. If they are not VA eligible, then we can help get them connected to the Executive Office of Veteran Services, which is, and then they can be provided assistance through EOVS. We work doing a couple of different diversion programs in Massachusetts. One is Brave Act. So we're able to receive referrals from trial courts and do assessments with veterans and provide treatment recommendations to the court and updates at different status hearings. The second is Veterans Treatment Court, and each county in Massachusetts has a Veterans Treatment Court. For Middlesex County, the court is located out of Framingham District. And a Veterans Treatment Court is, it's a bit different amongst the different counties. Most of them are post-disposition. And so we are essentially a period of probation that is with the exception of the Veterans Treatment Court out of BMC. And generally the program is about 2 years long. It's a very intensive period of probation where veterans have 5 phases that they go through. Each veteran has an individualized treatment plan and several different requirements through probation as well. And we're able to help get veterans connected into treatment court. Oftentimes we receive referrals from trial court, from attorneys, from sort of from all over, and we're able to, again, help engage veterans into treatment. And if they do participate in Veterans Treatment Court, then able to provide them with as much supports as possible. We also help identify veterans that might be incarcerated and then are able to outreach them to see if they're interested in receiving any VA services, and we're able to help get veterans determine their eligibility for VA and get them engaged into care and help develop treatment options for them, or treatment plans and referrals for them if they are both being held pretrial and are pending release, or if they are coming out after serving a sentence. Other factors that sort of go into our program is that we try to address sort of the myriad challenges that exist for folks that are engaged in the justice system in order to be able to overall address some of the risk factors that are associated with suicide risk. And we do that, again, by trying to get veterans connected into treatment, as well as information about how they can apply for VA benefits if that is needed. And as Dr. Park was saying earlier, we have several case management housing opportunities for veterans to be able to become engaged with. And so we try to address, any needs that a veteran might have that has some sort of involvement in the legal system.
Thank you so much. And to kind of continue on the what Bedford VA offers and what we ask of the task force is that we have the staffing and the capacity and the logistics and the SOPs to accommodate more veterans, to treat more veterans as an outpatient basis. Relationship program is our bottleneck, we are doing everything that we can for to kind of get the Office of Community Care funding to be dispersed so that they can treat our veterans. But if there's a way for veterans to get Mass Health or any other insurance programs so that they can be treated in a non-VA relationship program, that'll help the treatment access. When it comes to outpatients, send them our way. We'll try to get them to treatment as soon as possible. And so the current public health emergency extended from the COVID is still in place, that we can still start medications such as buprenorphine medications without seeing them in person first. So that extension has been the deadline has been extended to sometime in 2025. Without that exception, the Ryan Haight Act states that we have to evaluate them in person before we can start prescribing buprenorphine products. That's not the case at this time. So we can see them virtually, and we can send them medications. We can ask Northampton VA or other CBOCs to help us monitor them, their tox screens. And from our own internal review, we have not seen too many overdoses, as DA Ryan mentioned, that we have seen decrease of the overdose death. Probably the biggest risks that we see are the patients who've recently been cut off of their opioid prescriptions and the veterans who were recently released from incarceration. If there's a way for veterans to access treatment even faster coming out of incarceration. We are willing to collaborate with the jail system. We are willing to see them like on the day of their release from the jail, so we can get them into treatment. And that's one thing that that's one of the several requests that I do have for the task force. And I will stop and see if there's any questions from the team.
Thank you. Questions, comments for Dr. Park or Amy? No? How does someone send in a referral?
How do you send a referral? So if it's not visual, so they can just call the hospital, but I should have had that prepared for slide. That's a very, very good question. They can come to our walk-in clinic or urgent care, which is open from Monday through Friday for 8 a.m. to 4:30 p.m. They can call our main number and ask to speak to someone at a psychiatric walk-in clinic. And if they have if they are seeking care for opioid use disorder, walk-in clinic knows to call me. I personally take as long as I'm working, I'll take those calls personally to make sure that we can help them in a timely manner. Now, the walk-in clinic staff can now then walk them through referral to, if they need an inpatient detox, they'll ask them to come in. But if they'll navigate them the referrals for residential program or other services, if they're not in need of getting on a medication for opioid disorder right then and there.
Thank you. Anyone else? Questions, comments? Thank you both so much. Thank you. Our next speaker is Dr. Rendell Bolton. Dr. Bolton holds a PhD in health policy from Brandeis and has a multidisciplinary background in public health, social work, and psychology. She is a health services researcher at the VA's Administration Center for Healthcare Organization and Implementation Research, where she takes her expertise and applies it to study person-centered health system transformation. And she's looking to optimize the coordination and delivery of the whole person approach, something we've been hearing a lot about in the last few weeks, to ensure that patients' priorities remain central, even when their care might be shared across several clinicians or settings, particularly when people have a complex condition like chronic pain. And Dr. Bolton's going to talk today about the VA's Whole Health Initiative and the changes they've made to their approach to pain management. So, Doctor, thank you for being with us.
Thank you so much. Really honored to have the opportunity to talk with this group today. Let me go ahead and share my slides. Okay, can you see those okay? Mm-hmm. Wonderful. So I'm going to bring a slightly different perspective. I think it will dovetail really nicely with what Dr. Adams presented and what Dr. Park discussed. And I'll be sharing about this transformation that VA has been undergoing nationally towards a whole health system of care with an eye towards reducing or better addressing chronic pain and thereby reducing opioids. So I just want to start by noting that the views I'm sharing with you today are my own. They do not necessarily represent the views of the VA or of our funders. And the funding for this work comes from a variety of different sources. It's been funded by VA's Central Office of Patient-Centered Care and Cultural Transformation, the VA Quality Enhancement Research Initiative, and the VA Pain Opioid Consortia for Research. I'm also just noting here collaborators on the research that I'm presenting today. You'll see I have a couple names here highlighted in blue. These are people who have led some studies. I'll be sharing briefly results from their work as well as my own. And then in green at the bottom, Dr. Benjamin Kligler is the director of the Office of Patient-Centered Care and Cultural Transformation, who is leading VA's whole health transformation. Just to sort of lay out an agenda for what I'm going to talk about briefly today, I'll give a little bit of background on chronic pain. As DA Ryan mentioned, this is really a very widespread problem within the veteran population and directly related to the opioid epidemic. I'll then be sharing a little bit about VA's whole health system, what this is and what we mean when we say whole health, the impact that this has had on veterans. I'm going to share a little bit about one local initiative underway at the Bedford VA, and then some brief discussion points. So when we talk about chronic pain, I want to first just sort of set the stage and distinguish that from acute pain. So acute pain is pain that lasts less than 3 months. Its cause is usually known, and it improves as the injury or illness heals. And chronic pain is pain that persists longer than 3 months. We don't always know its cause or etiology, and it often persists even beyond the time that would be expected for healing. And so there's a very high prevalence of chronic pain among military veterans. About 65, 66% of all veterans experience chronic pain within their lifetime. And I think some recent statistics that about 5 million veterans had a diagnosis of chronic musculoskeletal pain. And there are wide effects associated with chronic pain. These lead to functional impairments, psychological problems. They affect people's relationships and work lives, can result in a financial burden, as well as a range of other socioeconomic impacts. Also attributed to and associated with opioid dependence, overdose, death, much higher risk for suicide compared to a non-chronic pain population. And this last number is just across the United States generally, including civilian populations. Chronic pain costs the United States about $650 billion annually in healthcare expenditures and lost wages. So when we think about addressing chronic pain, we really approach this from a sort of psychosocial understanding of chronic pain. So it's not just the sensation of pain itself, but we understand chronic pain as having physical impacts, behavioral challenges, social and environmental effects, and factors that influence chronic pain, and emotional and cognitive factors. And so because of this, when we think about treating chronic pain, we really want to take a multimodal approach that prioritizes non-pharmacological therapies first. So these include physical and movement-based therapies. This could be physical therapy, occupational therapy, as well as methods like yoga or Tai Chi. Cognitive and behavioral interventions. These include things like cognitive behavioral therapy, as well as mindfulness and meditation. And then providing support and engaging veterans in ways that they can support themselves and sort of self-care opportunities. And then that is followed additionally by medications and procedures when necessary, with opioids, only coming into play when absolutely needed. And within the VA, we are now thinking about chronic pain treatment as being a multidisciplinary approach to care and a whole person approach to care. And the VA has implemented policies and initiatives directly in response to the Comprehensive Addiction and Recovery Act that was passed in 2016, as well as putting policies in place related to pain reduction and opioid reduction, and then coverage mandates for non-pharmacological approaches to better address chronic pain. And one of the ways that VA is attending to this is through the whole health system of care. So let me start by talking about what is whole health. So the Institute of Medicine, or National Academies of Science, Engineering, and Medicine, as it is now known, put a report out about 1.5 years ago that defined whole health as the physical, behavioral, spiritual, and socioeconomic well-being as it's defined by individuals, families, and their communities. And whole health care is an interprofessional team-based approach that's anchored in trust, longitudinal relationships. It promotes resilience, prevents disease, and restores health. And it really intends to align care with a person's life mission, aspiration, and purpose. And then a whole health system is a collaborative and comprehensive healthcare delivery system that includes both comprehensive medical care as well as integrative health options. And under the Institute of Medicine's conceptualization, this would also then link to community programs, social services, and public health. And VA has really been working on implementing their own whole health system of care for about 12 years now. And within VA, whole health is an approach that empowers and equips veterans to take charge of their health and well-being so that they can live a meaningful life as they define it. It really is this idea of shifting how we approach healthcare from the question of what's the matter with you to thinking about what matters to you and then how can we support you in order to achieve that. So whole health also recognizes that health and well-being is influenced by multiple life domains and has services, I'll talk about this in a minute, in place to help veterans improve well-being across these dimensions. The whole health transformation has been underway since about 2012. And as I said, it's being led nationally by the Office of Patient-Centered Care and Cultural Transformation. So the whole health system really has 3 major components. The first is this sort of person-centered clinical care approach in which we begin to understand what veterans' mission, aspiration, and purpose is and incorporate their life context so that care really aligns with what matters most to them. Veterans are connected to well-being programs to help build skills, self-care, provide support to them, for example, through whole health coaching, and then connecting with other well-being programs and services. And then in addition to this, alongside the whole health system, 9 different evidence-based complementary and integrative health therapies have been implemented across VA. There are coverage mandates for these therapies. And these are particularly important for veterans with chronic pain to provide them with options other than opioids to help them better manage their pain. And the early goal of implementing this system really was to better address chronic pain, to reduce opioids, improve well-being, and better engage veterans in their health and well-being and healthcare. So I'm going to give a very sort of 60,000-foot level impact of an evaluation that I've been conducting along with a team of about 20 other researchers across VA and the impact that this is having on veterans. So in the fall of 2017 or the beginning of fiscal year 2018, VA funded 18 healthcare systems nationally to demonstrate whole health system transformation. And they funded the center that I'm a part of, which is the Center for Evaluating Patient-Centered Care in VA, to evaluate the implementation of the whole health system in these 18 sites and the impact that this system had on veterans. And so as part of this team, there were multiple, I think, across this team, we've now done about 50 different studies on whole health implementation and impact I'm going to talk just about a couple of those, including one that I led. So this team, during this 2-year period, in the 18 flagship sites, tracked implementation progress over the 2 years. We examined healthcare records and utilization records for a cohort of 335,000 veterans who had identified chronic musculoskeletal pain. We also compared opioid prescriptions for veterans with chronic pain who used whole health and CIH services compared to those who did not. And then we did repeat surveys over time with a subset of those veterans who also had chronic pain. I'm going to talk about that cohort of veterans, the 335,000 veterans. So all veterans in this cohort have chronic pain. They are similar to a veteran population generally. They have not only chronic pain, but multiple types of chronic pain. 56% had more than one type of chronic pain. They also had high rates of other comorbidities, including hypertension, diabetes, obesity, and then depression, and other psychological comorbidities that I don't show listed here. And these are also, you'll see down here, service connected. These were veterans who have a disability resulting from their time in the military service. And over a 2-year period, we tracked both implementation of whole health and use of complementary and integrative health therapies among this veteran cohort every quarter for 2 years. This is a messy graph. What this intends to show is how CIH use shifted over time in all of the 18 sites. And mostly what I'm showing here is there's some variation in this by site and over time. And then we also saw progress in whole health implementation and transformation over the same 2-year period in each of the 18 sites. Over on the left-hand side, you'll see these are stages of transformation. It represents how far along those healthcare systems were in implementing a whole health system, which is not just putting services in place, but also hiring staff, training people in new approaches for how to work with veterans using a whole health approach, changing billing and coding practices. So sort of a wide range of transformation that's happening in these sites. So when we combined this data together, what I found, this is the work that I did as part of my doctoral research, is that for sites that had implemented the whole health system, patients in sites with advanced transformation were more than twice as likely, almost 3 times as likely, to access and use non-pharmacological therapies for chronic pain. So when we think about the stigma that is associated with getting treatment, this is a way that veterans can get treatment for chronic pain without reliance on opioids in a non-stigmatizing way. Connection to whole health happens through their primary care providers. And is accessible for all veterans. We looked specifically at the impact on veterans with chronic pain, but this is really intended for all people with a focus on improving well-being. As part of my work, I also went in and looked at charts for a subset of patients. I read through the clinical notes that had been entered by their providers over 2 years. To really understand what was it about the whole health system that was helping veterans then get into these services to better manage their chronic pain. And what I found is that veterans, about 30% of veterans were really getting connected to a whole health coach. And it was through a whole health coach that was then being able to link what mattered to them to treatment approaches and getting them engaged in those approaches. So this is just some excerpts from clinical notes. And here, a veteran had back pain, declined acupuncture or chiropractic care, but a consult was placed for a whole health coach. The veteran then began to work with the coach, set a SMART goal to strengthen their mind and body, increase their mobility, and wean themselves down from medications. And then after that, got connected to acupuncture. So it was really through the coach that this improvement was happening. Just want to give a brief overview of some other impacts done by my other colleagues. So Dr. Stephen Zelliat and Dr. Barbara Bacour have looked at the effect of opioid prescription or whole health on opioid prescriptions and found significantly greater reductions in the use of opioids after participating in CIH and whole health services compared to veterans who only used conventional care. We also saw greater improvements in care satisfaction, perceptions of care, help reaching personal goals, and engagement in healthcare decisions. This is from a survey of 6,000 veterans. A separate study found improvements in healthcare quality and outcomes, including improvements in diabetes and blood sugar control, blood pressure, and smoking cessation. And then we've also found an impact for veterans who engage in whole health, who have mental health conditions. They were more likely to then start and complete evidence-based treatments for mental health conditions. And so when we think about the population of veterans with substance use struggles, with opioid addiction, and we can sort of see this impact more broadly with the whole healthcare system, not only just on reducing opioids, but improving well-being, improving engagement in other types of care, such as mental health care and other comorbidity care. I just want to give a very quick local shout out to my colleague, Dr. Justine Hyde, who is now leading an initiative and study within Bedford VA's residential treatment program to integrate a whole health approach into this program. This is still underway. Early results have showed that veterans who participate in this program and connect to CIH services are then more likely to complete the program. Dropping out of this program this is discussion points here, and then I'll stop. Whole health is a promising approach. It has a widespread impact on veterans' health and well-being. A lot of research is underway in this area, and then whole health is also spreading beyond the VA. It's making its way into other healthcare systems, other initiatives, through NIH and others. And then I have a link here for those who would like to learn more about this initiative. So thank you.
Thank you, Doctor. Thank you. Questions, comments? Oops. No?
I don't see anything.
All right, thank you. And now we're going to talk a little bit about something that many people here have already heard us talk about, and a partner that has been very good in working with us on these initiatives, has really done a lot of work in the greater Lowell area, and that is the Bridge Club. And the Bridge Club, among its many offerings, has a Veterans Bridge Back initiative. And Randy Carter, who's the Veterans Services Program Manager, who has decades of experience working with veterans, addressing their unique issues, is here to talk to us a little bit about that program. Andy.
Hi, good afternoon. I wouldn't say decades, but that's okay.
That's what Bob told me, decades and decades.
So yes, my name is Randy Carter. I'm the program manager here at the Bridge Club of Greater Lowell. I have about 15 years of experience working with the homeless veterans with substance abuse. and alcohol abuse and post-traumatic stress. I am a veteran myself. I spent 25 years in the Air Force. I retired in 2007. I do use the Bedford VA a lot. I can actually say from my own experience how things have changed over the last decade, that for the better, and the extensive work that the teams are doing there. Bob Cox had brought me in because the Bridge Club of Greater Lowell deals with substance abuse, and they deal with reentry into the workforce, reentry into basic everyday life. And they do a lot of recovery work here. But there was just that little niche that was missing. So they applied for what's called the Homeless Veteran Reintegration Program. They were awarded the grant in June. Unfortunately, I wasn't available to come in June. So I started here in September. And what the program does is we take veterans who are homeless or at risk of being homeless, who are either suffering from an addiction or mental health problem, and we get them ready to go back to work. So once we get them assessed and we attack their issues, and we get them to a point where they could go back to work, now we figure out what they could do, because what they could probably do 10 years ago, they can't do now, or vice versa. Or maybe they can't work in a different environment where there's a group of people. Maybe they have to work solo. So we take all those into consideration when placing them. So we work with the local employers as far as teaching them what a veteran needs if he suffers from PTSD. A lot of you may know sometimes a veteran just needs to get up and walk around. Sometimes they just need to be left alone. Maybe they don't need that 15-minute break when it's assigned. Maybe they need to take it when they feel they need it. Also working with a lot of partners in the area with veterans who have service dogs. A lot of non-military, I don't want to say non-military friendly, but people just aren't used to working with veterans, don't understand that the service dogs have just as much rights as the owner. And they have federal rights, and it is a criminal offense if you were to deny somebody employment because of that. So speaking of all that stuff, the Bridge Club is open 7 days a week, 365 days a year. They do 3 or 4 meetings a day, plus night meetings, plus we have walk-ins for people in need of services. Again, I am on the veteran side, so if a veteran was to come in, we do a quick intake. And if we have to take them to Bedford, we will. Or if they prefer not to and need to go to local, from local agencies, we can do that. We have other partners there. So when a veteran walks in, first thing we do is we do an intake. We want to find out where they're at, why they're homeless, or why they're at risk of being homeless, why aren't they working, why haven't they been working. And with that, we're able to get a game plan going. Still teaching some of the people what a IEP is and how to work with them and how to create one. And it's basically a step-by-step, it's a roadmap on how to get the veteran back into the workforce. A lot of times we have veterans who are getting older and they want to be a supervisor instead of being the one actually doing the labor. And it's hard for them if they have no supervisory experience. So we try to help them with that. We try to get them supervised, maybe not as a supervisor, but in a position where they can grow into that field. We have some gentlemen or even some women who are in the construction field. They just can't physically do it anymore. So we try to help them get into something that will suit them because of their physical needs at the time. Then again, they may want a complete career change. So we offer vocational training here. We have a lot of in-house programs for both veterans and civilians. We're getting ready to launch our culinary program, which I'm excited about. I'm Italian. I like food. And the director of the culinary program at the local vocational school will now be the man facilitating it here for veterans. They'll be able to come in here on an 8-week program. And instead of just throwing them into a job in a restaurant, we're going to give them firsthand knowledge on how to work in that restaurant. Everything from what each machine does and how it works to different color cutting boards, which I didn't know existed, but each cutting board has a different meter. We also have a contract with New England Tractor Trailer School. We just graduated 2 more veterans recently from that program, which they are great. And we've just been recently awarded the title of community partner for Amazon, even though figures are on strike today. But Amazon now is a partner, we're a partner with they're a partner with the Bridge Club, we're a partner with Amazon. So they will do direct hires from us straight to their warehouse in North Andover. Along with that is Restaurant Depot. And also with all our veterans or even non-veterans who are coming into the program, we offer 2 years of transportation to and from work. So they'll come here, we'll drive them to work, and then we'll be there, we'll have a driver there to pick them up. Switching gears a little bit, incarcerated veterans or incarcerated people. We've just been granted approval to actually go into the larger scale prisons to start working with the veterans and people who are ready to be released. It's sort of like a pre-release program, but we'll be able to talk with them about what is available to them, how to obtain some of their benefits, what benefits they may not be available for. A lot of veterans don't know once they're incarcerated, if they have a disability, it gets dropped down to 10%. And then they think it's gone forever, but we can assist them with getting that back when it gets out. We have a couple in local prisons now that want to get involved in recovery, becoming a recovery coach. So we're able to help them start that process. And as far as the incarceration part is going on, yes, I have already emailed somebody here today to ask for assistance, if she hasn't left yet. But I think a lot of times a veteran is not saying they deserve special treatment, but sometimes it doesn't warrant the arrest that it is. So working with local police departments, I've been able to assist with veterans who suffer from post-traumatic stress. And instead of giving them a moniker of a domestic violence or assault or something, try to work with the veteran and try to work with the local police departments and the district attorney to maybe circumvent that if they agree to go to therapy or go to training or getting some kind of mental help. We recently had a nurse. He's a NICU nurse, which is another new word I didn't know. He worked as a NICU unit in Boston with a felony. He would lose his license as a nurse. He had a spotless record. He hadn't drank for 15 years. His girlfriend got up, left him for his best friend, took his bank account, and he drank his sorrows away and didn't end well. But with the work of the vet court, we were able to intervene and work with this gentleman to keep his license. And he's actually in a better place today. And he actually gives back a lot to the different veteran agencies around to share his story and to seek help when they need it. I don't have anything in depth like you guys have, but that's basically what some of the other things we're doing. We're in talks with the Archdiocese to take over a convent, which will house 30 bedrooms. And we're hoping to make that either a transitional or emergency bed program. We also, we've applied for the emergency bed grant out of Bedford. It's 15 beds. We're waiting for the award for that. Hopefully that will come through soon. Right now, we have a property in Drake. Don't know if they're going to wait another month or so before the funding is released. We hope so. So if anybody's got a house so it can house 15 people, let me know. And my goal here is to make the Bridge Club a veteran one-stop shop. So right now I do all claims, disability claims that come in. I help them get their 214s. We assist them in getting health care. We assist them in disability. We assist them in maybe getting food stamps. So we want a veteran to feel like they can come here and it's a one-stop shop, because the worst thing to do is have someone being bounced around, especially, not about the VA, but it took me years to learn that tunnel system there in Bedford. You get stuck in one of those tunnels, it's almost like you don't know which way is out. But the more we can do here for the veteran is less that the Bedford VA has to deal with the mundane stuff. So they can focus on the treatment that the veteran needs. And that's about it. Any questions? Come on.
Questions, comments? Thank you all. This was a good set of services and programs and what's available for a population that really needs our services and that we know is often struggling and sometimes not sure where to go with that. So thank you all for being with us today. Anybody have any updates or things they want to share with the group? All right, hearing none. Thank you all for being with us. Have a wonderful holiday. I look forward to seeing you all in January. Thank you.
Thank you so much.